Hello, I'm Dr. Jonathan Bernstein, professor of medicine from the University of Cincinnati and partner of the Bernstein Allergy Group and Bernstein Clinical Research Center. And today I'm going to present some of the highlights on hereditary angioedema from the 2021 American College of Allergy, Asthma, Immunology meeting. So what is hereditary angioedema? It's a rare genetic condition that's associated with a deficiency in C1 esterase inhibitor, which is very important for regulating the production of bradykinin that, if it goes unchecked, can lead to swelling episodes that can involve different parts of the body. And in the most severe cases, the larynx, that can result in asphyxiation and death potentially. The two types of hereditary angioedema are type 1, which is the most common, seen in about 85% of patients, where there's a dysfunctional C1 inhibitor protein, but also a quantitative deficiency of this protein. And about 15% of patients have dysfunctional C1 inhibitor protein, but they actually make the protein, it just doesn't work well. And in both cases, excessive bradykinin production is the cause of these swelling episodes. Now, the American College of Allergy and Asthma and Immunology was held in November from the 4th to the 8th in New Orleans, and there was an option to attend the event virtually via live stream as well as in person. Abstracts were published in the Annals of Allergy, Asthma, and Immunology. Due to the pandemic, most of the audience was virtual, and that limited participants' ability to properly assess accumulative data from abstracts presented. So let's talk about some of the highlighted abstracts pertaining to HA that were presented at the ACAAI meeting. The first is called the APEX-S study, and this is investigating berotralstat, which is commercially known as Orladeyo, and it's been approved by the FDA for the preventative treatment, prophylactic treatment of patients with HAE. It's administered as a 150 milligram capsule once a day. And this first poster was presented by Dr. Mark Rydell, and it was entitled "Berotralstat Demonstrates Low Hereditary Angioedema Attack Rates in Patients Switching from Injectable Prophylaxis." And they evaluated the safety and efficacy of berotralstat 150 milligrams once a day in 34 hereditary angioedema patients in the United States who completed 12 months of treatment in the open label international APEX-S study. They found that the mean monthly attacks were consistently low following the switch to berotralstat, and overall the transition from injectable HAE prophylaxis to berotralstat was generally well tolerated. You can see in the figure below on the left the monthly HAE attack rate following switch to berotralstat, which averaged somewhere around 0.4, 0.5 attacks per month. The median attack was actually 0. The mean attacks, again, were just a bit higher based on the data analysis. And you can see the most common side effects were vomiting, diarrhea, some upper respiratory tract infection, nausea, insomnia, pharyngitis, abdominal discomfort, and back pain. But none of the patients dropped out of the study due to these side effects. The second study also is pertaining to the APEX-S study, and this is a study I presented, and it was entitled "Improved Patient Satisfaction with Berotralstat in Patients Switching from Injectable Hereditary Angioedema Prophylactic Therapy." So this was an analysis that looked at the treatment satisfaction questionnaire for medicine. This is a validated instrument that patients answer during the trial. So patients evaluated this study evaluated patient satisfaction after switching from injectable prophylactic therapy to berotralstat 150 milligrams once a day in 34 HA patients that were evaluated in the previous study I just presented. And the higher scores of this TSQM questionnaire indicate greater satisfaction. So you can see that overall, the mean improvements were observed in all domains of the treatment satisfaction questionnaire for medicine from baseline to month 12 in patients on berotralstat. So you can see the baseline is in dark blue, and then at month 12, the lighter blue, and you see global satisfaction, convenience. Effectiveness is about the same from baseline, and the side effects, again, people were generally satisfied with not bothered by the side effects terribly. Now, the next study is also from, this is actually a study that is looking at switching to berotralstat following placebo, and the author, Sion, presented this, and is entitled Sustained Reduction in HAE Attacks, Attack Rates Following Switch to berotralstat. It's a subgroup analysis from the APEX-2 study. So this evaluated long-term efficacy and safety in 17 HAE patients who switched to berotralstat monotherapy after receiving placebo. And this was part of the study design in part 1 of the APEX-2 randomized controlled trial. In part 1, patients were randomized to receive berotralstat 110 milligrams or 150 milligrams or placebo once a day for 24 weeks. And then in part 2, patients were re-randomized 1-to-1 randomization to receive either berotralstat 150 milligrams or 110 milligrams once a day for an additional 24 weeks. And then finally, part 3 was the open label extension with berotralstat 150 milligrams once a day. And what we see from this is that there is an overall sustained reduction in attack rates observed following the switch to berotralstat, indicating the effectiveness of this therapy for HAE prophylaxis. Here we see part 1 at week 24, there was a reduction in the adjusted attack rates per month. And then at week 28, we see a further reduction. And again, this is a sustained, and then in the part 3 study, which was the open label extension, there's a sustained reduction in attacks through week 96. Now we can switch gears and talk about another agent called lanadelumab, and this abstract evaluated the long-term efficacy of lanadelumab in HAE. And again, this was also presented by Mark Rydell, and it was entitled Attack-Free Status and HELP Open Label Extension. It's a long-term lanadelumab prophylactic treatment for 12 months or longer. And in the HELP open label extension, attack-free periods of 6 months and 12 months were achieved by 81.8% and 68.9% of patients in the overall population, respectively. And in this presentation, the attack-free status for patients treated for over 12 months was analyzed. Rollover patients received lanadelumab 300 milligrams on day 0, then 300 milligrams every 2 weeks after the first attack. Again, this was the regular dosing period. And then there were non-rollover patients who just received 300 milligrams every 2 weeks from day 0. And this is the table shows the percentage of patients who remained attack-free following lanadelumab. You can see in patients who rolled over, the attack-free number of patients was 69.9% at 12 months, and then two greater than 24 months, and at 24 months to less than 30 months, it was 74.2%. And we see very similar results in the non-rollovers, maybe just slightly reduced in the 24 to less than 30 months. But overall, there was a 71.4% of patients who were taking lanadelumab between weeks for 24 to less than 30 months were attack-free. So in conclusion, from this study, in HELP open label extension, a consistent percentage of patients were attack-free within fixed 6-month intervals from month 12 to 30, demonstrating sustained efficacy of lanadelumab in long-term prophylactic treatment of HAE. Now, the next study was looking at determining the best measures for patient-reported outcomes in HAE patients, and this was presented by Dr. Ye et al. The relation, again, was entitled The Relationship Between PGIC Scale and Other PROs, and this is an ACAAI study, KVD 900 trial. They actually have an oral kallikrein inhibitor as well. Again, they evaluated the relationship between 3 patient-reported outcomes in HAE. Patients were randomized to treat eligible HAE attacks within 1 hour of onset with the KVD 900 600 milligram capsule or placebo, and the reported outcomes were patient global impression of change, the visual analog scale, and also patient global impression of severity. And 60 patients completed treatment for 1 attack. Again, these patients were using this therapy, this oral therapy, for on-demand treatment. When they had an attack, they would take the medication. And they rated this a PGIC, which is the patient global impression of change, scoring of a little better at 2 consecutive time points. They had 97% sensitivity compared with composite visual analog scale or the patient global impression of severity improvement score. Descriptive comparisons of the PGIC, the VAS, and the PGIS measured are shown in the table. You can see that for a little better, the PGIS had 97% sensitivity. So did the composite VAS, which was the improvement greater than or equal to 50% decrease from baseline. But looking at better, when they rated it as better, these sensitivities and seem to go down a little bit, but the specificities actually increased. So overall, compared with PGIS and composite VAS, the authors found that PGIC scoring was of a little better at 2 consecutive time points, was a sensitive endpoint for identifying improvement within 24 hours. There was substantial and positive agreement with the PGIC and other PIOs, which suggests that improvement on the PGIC was clinically significant from the patient's perspective. And this is very important when you're looking to really assess patient outcomes and satisfaction with therapy. Now, the next study was another poster I also presented. It was entitled On-Demand Oral Treatment with KVD 900 for HAE Attacks Achieve Rapid Exposure and Improves Patient Outcomes. And this study evaluated the pharmacokinetics and effects on patient-reported outcomes of KVD 900. Again, as I mentioned, this is an oral plasma kallikrein, which was in this study being used for the treatment of acute HAE attacks. Again, a single 600 milligram dose of the open label KVD 900 was administered in the clinic, followed by a double-blind placebo-controlled crossover trial treating HAE attacks. Pharmacokinetic parameters were measured and symptom improvement was assessed using a patient global impression of change, as I mentioned in the last poster, on a 7-point scale. Within 12 and 24 hours, more patients on the KVD 900 reported HAE attack as better or higher on the PGIC score than placebo. The median time to improvement was statistically significant, shorter, and it was significantly shorter with KVD 900 compared with placebo. So 5 versus 15 hours. And that's a significant p-value. So in the table, you can see that in patients receiving the active treatment, there was a significant greater number of percentage of patients reporting improvement receiving the active drug versus placebo at 12 and 24 hours. And the median time to improvement as well was statistically significant for the KVD 900 at 12 and 24 hours. So in conclusion, treatment of HAE attacks with KVD 900 achieved rapid plasma exposure and faster improvements in patient-reported outcomes compared with placebo. Now, there are also a number of case studies that were listed that were presented, which are interesting always to see what people are seeing in their clinics and how they're, and they do give us an idea of real world experiences. One study was worsening angioedema in a patient with a diagnosis of HAE, and they looked at, they found that C1Q, they reported that C1Q, which is well known, is normal in 30% of acquired angioedema. These are patients acquired angioedema who actually have, they look like HAE, but their angioedema is caused either by an autoantibody directed against C1 inhibitor or an underlying lymphoproliferative disorder that consumes assumes complement. In many cases, however, it cannot be distinguished from HAE from complement levels alone, because the C1Q is the test that we use to, if it's low, to differentiate between HAE, but sometimes it can be normal. Therefore, in patients with a strong family history and relatively late age of onset, acquired angioedema should be strongly suspected despite a normal C1Q. Again, they also recommended the lymphoproliferative disorders should be screened in patients suspected of this condition. So this is just an experience. It's not anything new, but something that reinforces what is currently recommended. The next was a study by Dr. Jones, who reported joint pain as a rare symptom in patients with HAE with normal C1 inhibitor. Now, normal C1 inhibitor patients are a little more difficult because we still don't understand the pathogenesis. They have normal C1 inhibitor functional quantitative levels, C4, C1Q, but they swell. And it's believed that there are at least some of the pathways that are involved are similar to the pathways involved in hereditary angioedema. Joint pain, which is not associated with angioedema attack, however, in this case was proposed to be, was found to be present in this patient with normal complement C1 inhibitor. And again, they hypothesized that possibly a comorbid endocrine and immune dysregulation was present in this patient. But again, this is more of a descriptive case and nothing to shed any mechanistic understanding of what is going on. Next study was presented by Shapiro, which was an unusual presentation of HAE. And again, this situation, recurrent UTIs, intermittent idiopathic episodes of abdominal bloating, and a family history of intermittent idiopathic episodes of abdominal bloating, as well as a decreased CH50 and C4 and low C1 inhibitor, C1 esterase inhibitor, quantitative and function, may indicate HAE, even if there's no family history. And we do know that patients, 25% of cases of patients with HAE have no known family history. These patients have a de novo mutation in their C1 inhibitor gene, in their SERPINE gene. Again, a few other cases. One was reporting autoimmune lymphoproliferative syndrome presenting as recurrent fevers in HAE with normal C1 inhibitor. Another was looking at hereditary angioedema presenting as abdominal pain, trying to emphasize the importance that we should be recognizing that patients may not always present with classic symptoms of swelling of the extremities, and abdominal pain may be the presenting symptom. Another study which looked at novel SERPINE G1 mutation in a case of HAE, and again, they wanted to emphasize that it's important to consider C1 inhibitor deficiency in the differential diagnosis of angioedema without urticaria, regardless of age of onset, and that they also observed a decrease, that they also emphasized that decreased C1Q levels can be seen in HAE, although it's rare, it can be seen, and that's why we have to be able to differentiate between HAE and acquired angioedema. And the other case was a blepharochalasis in a hereditary angioedema as a hereditary angioedema masquerader. Some people have recurrent angioedema, and it's important to have a differential diagnosis to see what other conditions could be causing the swelling, as it may not always be hereditary or acquired angioedema. In fact, these are rare conditions, and it's more likely than not when someone presents with isolated angioedema, it will be a different type of angioedema, but we have to be able to rule these cases out. So in summary, HAE is a rare disorder associated with overproduction of bradykinin. The ACAAI 2021, which was held in New Orleans this past year, was a great forum to attend personally or through live stream. And it's important that we emphasize some of the abstracts published, because they were not always probably fewer observers for the abstracts, given that the majority of the attendees were virtual. So we have reviewed several agents that are now approved: berotralstat, an oral kallikrein inhibitor, and lanadelumab, which is a subcutaneous kallikrein inhibitor, both for prophylactic treatment, and both have showed to demonstrate reduction in HA attacks. The novel compound yet to be approved by the FDA for KBD 900, an oral kallikrein inhibitor, which is being investigated for acute HA attacks, showed that it was effective in reducing the time to resolution of HA attacks. And again, understanding patient-reported outcome measures is very important when one does clinical trials, but also when looks at these patients in the outpatient setting, because these patient-reported outcome measures should be used by clinicians in assessing patients' response to treatment longitudinally. So HA also, as we saw in some of these case reports, can present a number of different ways, affect multiple body systems, and may be confused with other diseases. So it's always important to have a broad differential diagnosis. So that summarizes what was the highlights of abstracts pertaining to HAE at this past year's meeting. Thank you very much for your attention.